I think Dr. Dinesh Talwar has already done half the homework for me, so I'm just going to skip over the things which he's already mentioned. But my my main aim of the talk was to see where we are and where we're going to go in future, because we all know that we are in the VEGF era. We have got options in terms of what kind of VEGF you use, how often we use them. It's just a matter of deciding what is the best way of using. And just to very briefly tell you, the system is slightly different in the UK because the patients don't pay for the treatment. So the treatment is free, but that means that we have to be very careful to balance the capacity that we have, and at the same time to treat all the patients properly. So Dr. Talwar has already said what we are looking at. This is mainly in the terms of central scotoma and a distortion in the central vision. And what is the burden? To some extent, I don't have exact figures from India, but UK has a population of around 60 to 65 million, and we have more than 500,000 cases of active or advanced AMD. A similar picture in USA, and the incidence in India varies between 1.8 to 4.7%. Considering the population of India and the fact that the life expectancy of people in India is increasing as well, this disease is going to become more and more common. I have to say that the characteristics of the AMD is slightly different in the Asian population compared to the Caucasian population. So what we want to do is we want to move that scotoma away from the central vision so that the patient can regain as close to a normal vision as possible. So the key questions I'm asking you, the audience, is where are we, what are the current issues, and where are we going to go? So where are we? We are in the Lucentis era at the moment. So if we just categorize this, I mean, we are still nowhere in terms of dry AMD. And you have to remember that although wet AMD is in the limelight for many years now, it is its twin, the dry AMD, which is the most common one. And around 85% plus patients of AMD are dry. And what do we do for them? We virtually do nothing, except that there is enough evidence now from the AREDS 1 and 2 trials that if you give them the appropriate nutritional supplements, then in a significant number of patients you can slow down the progression of dry AMD. But there is still no preventive treatment or no treatment to stop. Then we had the pre-Lucentis era for wet AMD, and this was vast majority of cases, except for the extrafoveal CNVs, which Dr. Talwar mentioned. All the cases were virtually a one-way ticket to blindness. Now we are currently in the Lucentis era, and it's working very well. So we have a significant number of patients who we have managed to at least stabilize the vision, if not improve it. But there are issues with that. And then you are looking to go beyond Lucentis at some stage. So what are the current problems? Especially in this country, cost is a major issue. Even in the US, one patient for a whole cycle of treatment, it can cost up to $250,000, so it's not cheap. And then you have the burden of monthly visits. Whether you are following the PRN pronto evidence-based treatment or PRN treatment, you still have to see the patient monthly. And obviously the potential ocular and systemic adverse events, both short-term and long-term. And Dr. Talwar has already mentioned the 7-UP trial. What is also important to remember from that trial is that although around 70% of the patients still have active disease, 1/3 of the patients, their vision is 660 or less. It's only 1/3 of the patients who have managed to retain 612. But also importantly, if you look at the details of the trial, there's probably 98% of the patients who have been followed up from Anchor Marina and up to the 7 years after, they have evidence of macular atrophy. So subretinal fibrosis and macular atrophy are serious concerns with long-term anti-VEGF treatment, and we have to keep that in mind as well. So where do we want to go? In the very short term, this is what we want to do, especially in the National Health Service in the UK and other places as well. We want to reduce the burden of monthly injections. Now, all the treatment so far has been focused on pathology which has already happened. Is there anywhere we are trying to do something to prevent the damage? So that's one category of treatment which people are trying. And apart from some of the suggestions which Dr. Talwar made, combination therapy is one of the things which has been tried, and currently there are some randomized controlled trials undergoing with combination therapy as well. Obviously, in the longer term, novel, easier ways of drug delivery. Novartis has a drug in pipeline which has showed very good results in phase 2 trials, and probably will have a drug in the next 12 to 18 months, which will require injection only once every 6 months. So there are some drugs in the pipeline. Also, as I said, longer-lasting drugs, and then you have the genetic markers. It is still a little bit of a mystery as to why some patients respond much better than others, why some patients need very frequent injections, whereas other group of patients, you have 3 loading doses and then nothing happens, the disease is very stable. So there is evidence now that genetic markers are one of the factors which can determine how the patient is going to progress in terms of treatment. And then genetics modifying drugs are coming on as well. And then you have the stem cell treatment, which is like, if it happens, it's going to make the whole scenario completely different. So what we are dealing with today, and I'm going to go through this very quickly because of lack of time, is that only the first small step, how do you reduce the burden of monthly injections? And this is just a brief anecdotal talk at the moment based on what we are doing in the UK or what we plan to do in the UK. And basically, the first thing, which was also the title of my presentation today, but I've deviated from that, is we were looking at a study which was done by Urmila Mantel in Switzerland, and she called it Observe and Plan. And this was basically to ultimately design an individualized treatment plan for every patient based on the response. The problem with that was, although it significantly reduced the number of visits, it was a slightly complicated process, and at least in the National Health Service in the UK, we have different clinicians treating the patient at different times, and we found it very difficult to implement that in a continuous way. So we decided to abandon this plan. Instead, what we are trying to do now is, this is treat and extend. This is based on the TREX trial, and basically, if you look at the Americans as well, nearly 70% of American physicians are now following the treat and extend plan. So this is one of the, Dr. Talwar has already mentioned some of the drawbacks of this, but largely, I think, based on problems with the capacity and everything, this treatment works quite well and is suitable for most of the cases. And if you look at the evidence from the TREX trial compared to the PRN Pronto trial, the letter gained is significantly more compared to the previous trial. Now, this could be due to a slightly higher number of injections, and there was no sort of variability of PRN doses because, as Dr. Talwar mentioned, we have very, very strict retreatment criteria if you want to maintain the visual gain as close to the Anchor and Marina trials. But if different physicians are looking at the patients on different visits, then that retreatment criteria is not followed very strictly, and therefore, in real life terms, the results of the Pronto or PRN treatment are not as good as it was in the Pronto trial. So that variability is taken out in the TREX trial because the patient simply gets an injection every visit. I don't want to go into details now of the TREX treat and extend because Dr. Talwar has already mentioned that it is an individualized treatment because once the patient has completely dried up and the maximum vision has been gained, the treatment interval is extended. So the patient's visit is delayed by 2 weeks and so on and so forth until the patient needs injection again, and the treatment interval is shortened accordingly. So you can read it up. It's quite a simple treatment plan to follow. The other drug, which I don't know how common it is in use in India at the moment, but we have been using AFLIBERCEPT, or EYLEA as we call it, for at least 2.5, 3 years now in the UK, and my personal experience has been quite good. Initially, we started using EYLEA for the what we call the suboptimal responders or non-responders with Lucentis. Avastin is not in the picture in the UK, although we use it for our private patients, but because it's not licensed, we can't use it in the National Health Service. So we don't have a lot of evidence regarding Avastin, but I am part of the what we call the LEVO trial, which is being run by Moorfields at the moment. It's a different disease. It's for CRVO, but it is comparing aflibercept, ranibizumab, and Avastin for CRVO. So that should be a good, at least give us some indication of how these three drugs work, although for a different condition. But initially we started switching patients from Lucentis to aflibercept if they were non-responders, poor responders, and by poor responder I mean that they did respond, but the response was not ideal, or they needed very, very frequent injections. So we started switching those patients to EYLEA, and after the 3 loading dose, the biggest advantage we had was that these patients didn't need to be seen every month. They would be seen every 2 months. So that was a part of the reason. And then more recently, we have actually started treatment-naive patients. So the patients who have not had any treatment, we have started treating them with EYLEA instead of Lucentis. And one of the reasons is that EYLEA is slightly cheaper than Lucentis in UK, based on some kind of discount the company has given to the Department of Health. We do have some combination treatments, and as you know that in recent there has been, and even in past there has been incidences where combination therapy has been tried, and that's something which is in the pipeline as well. So the take-home message from my talk is that if we have made significant progress, but you need to look at the patient as a whole, because the time for just a blanket treatment for everyone is gone now. You have to individualize your treatment for every patient, and you can only do that by extending your treatment or switching them to different drugs. And you also have one point I would like to make is that what I've understood from here is that intravitreal injections here is largely a theater-based procedure. Is that correct? So we obviously don't have the capacity there to take every patient to the theater, because on an average we do around 40 to 50 intravitreal injections every day. And I don't know whether people would consider doing it as an outpatient procedure, as a minor. Then obviously you have short-term goals and long-term goals. And as I said, many people say, why not inject every month? Because that gives you the best results. But the long-term goals, you have to maintain the vision as long as possible. And if you carry on injecting very frequently, then obviously there is a risk of macular fibrosis and geographical atrophy. So I think in terms of the management of AMD, you have to be very dynamic. We have to be very proactive and treat every patient as an individual. Thank you very much. Thank you.